Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 4 of 4 of the Practice Changing Updates, the Evolving Hemophilia Treatment Landscape podcast series. I am Dr. Guy Young, Professor of Pediatrics at the University of Southern California and Director of the Hemostasis and Thrombosis Center at Children's Hospital, Los Angeles. I'm joined by my colleague, Dr. Angela Weyand. In this episode, we will discuss clinical case scenarios to examine the utility of novel non-replacement therapy and gene therapy. We'll illustrate the potential application of these novel therapies among diverse patient subsets and provide guidance to determine how different patients will benefit from these agents. A couple cases. I think we're running out of time, so I'll probably be very brief here. So we've got a 6-month-old. It's having lots of trauma-related bleeds, including mouth and tongue. He's gotten multiple doses of Novo-7 because he's had an inhibitor. And then you can see he's developed this factor VIII inhibitor after just very few doses, and immune tolerance was not attempted. And he started having, so now he's 2 years old, and he's having joint bleeds in his ankles and his knees, requiring a lot of Novo-7. And so now at 2 years of age, he's been on, he hasn't tried ITI. And we're still trying to get him to have his bleeds under control. So I guess here, which of the following options would be the best practice approach for you? And we'll let you go ahead and vote. You can see your options are efanesoctocog alpha, emicizumab, fitusiran, concizumab, and valoctocogene roxaparvovec. So essentially, 2-year-old with an inhibitor with multiple bleeds on Novo, despite getting Novo-7 for treating the bleeds. And now he's having joint bleeds. And looks like B is basically the number one answer here. And that's obviously the correct answer. So well done to you all. And then now moving along here, this patient is now, as he actually started fitusiran prophylaxis. Now that was on a clinical trial, obviously, and he's done well with that. Let's get to the next case. I think that's more valuable. So we have a 13-year-old boy. He's got 3 target joints, knees, 2 elbows, and a knee. He's been wheelchair bound at times. He has an ABR of about 20 over the past several years. Now, he has an allergic reaction to factor VIII, and for that reason, we've had to rely on factor VIIa to treat him. And on occasion, he was provided factor VIIa for bleed prevention, but it wasn't really working very well. So what would be the best practice option for this 13-year-old boy with severe hemophilia A, noting he has an allergy to factor VIII, he's bleeding a lot. Novo-7 is controlling the bleeds, but he doesn't have a good prophylaxis option. So let's go ahead and vote. Your options are efanesoctocog alpha, emicizumab, fitusiran, concizumab, and valoctocogene roxaparvovec. Yeah, certainly emicizumab would be an excellent option. I think here, depending on what's available, emicizumab or fitusiran or concizumab, of course, he has this allergic reaction, so efanesoctocog wouldn't be an option. He's too young for gene therapy. So any of those 3, and of course, the one that's available now is emicizumab. So in this case, yes, emicizumab would have been the best option. Turned out that because he's in my center, he gets options for clinical trials, and this family was interested in clinical trials, so he was started on concizumab. He's actually done really well. He's out of the wheelchair. He's not bleeding. And so he's done as well as what you saw in the Explore-8 trial with his bleed rate going down very low. And then finally, a 40-year-old man, so it's an adult. He manages his prophylaxis well without many missed bleeds, but he still has 4 to 6 joint bleeds per year. He really wants to minimize these bleeds. He switched to an extended half-life factor VIII at relatively high doses, but he's still having some bleeds. You can see his background is he's had moderate hemophilic arthropathy. So back to the polling question, again, with the same options you had in the previous question, what would be a best practice approach for this patient? Again, the options are efanesoctocog alpha, emicizumab, fitusiran, concizumab, or valoctocogene roxaparvovec. I think those are good options. I think, again, really almost any of these options could be considered for this patient, but I think in an adult patient who's really looking to really get bleeds under control, perhaps even improve quality of life, he was offered gene therapy in a trial and he ended up on valoctocogene roxaparvovec. So in the near future, as we get to the teaching point here, there'll be multiple new therapeutic options for persons with hemophilia A. And treatment decisions are going to be more complicated, right? When you have more options, it's more complicated. I use the analogy of, if you're going to go to a Subway, well, you don't have too many choices. You're going to pick a sub and put whatever meat you want in there. But if you go with a group of people to a restaurant that has, I won't advertise any, but that has multiple menu options, it can be more complicated. Do I want the fish or the steak, or last night I had pasta, maybe I want something else. So yeah, as the menu gets bigger, the decisions are going to get bigger. And the key point here is to follow a shared decision-making approach. You see one of them there, which is the SHARE acronym: seek your patient's participation, help your patient explore and compare treatment options, assess your patient's values and preferences, and then reach a decision. And after you reach a decision, of course, you have to evaluate the response to the decision and then move forward from there. And don't be afraid to give one therapy and then switch to another. The caveat there is, of course, gene therapy cannot be undone. So once you have the gene therapy, it's there. But again, if a patient does lose their response, they can go back on prophylaxis. So I think with that whirlwind there and trying to finish more or less on time here, I will stop, and we're happy to take some of your questions for me or Angela. Which other clinical trials are underway for emicizumab and efanesoctocog?
Yeah, so you probably know a little better than I do. I know there are a number of investigator-initiated studies for emicizumab, like in von Willebrand's disease and looking at sports participation. And then with efanesoctocog, I know that there's interest and planning for trying to collect data in POPs, which is the population they don't currently have really any data on, as well as using efanesoctocog like in von Willebrand's disease. But you probably know a little better than I do of others.
Yeah, no, I think you covered it. As you said, there's quite a number of investigator-initiated studies that have been funded by Genentech for emicizumab. You've mentioned a couple of them. And then really the main trial that's newer that's going on, you covered as well, which is HAVEN 7. If people are wondering what happened to HAVEN 5 and 6, sort of like what happened to Factor 3 and 6, HAVEN 5 was a study that was done in China. So it's a Chinese-only study, and it was required by the Chinese government to get approval there. And then HAVEN 6 was a study in mild and moderate hemophilia, which was really done mostly for Europe, because in Europe, the label was only severe hemophilia, and the European Medicines Agency required a study in mild and moderate hemophilia patients. In the US, we already had that approval, so it was less important for us, although some people did participate in that. So that's HAVEN 5 and 6. I'm not aware of any HAVEN 8, and HAVEN 7 may be the last one. And I think for EFA, I think this is the time that people who are interested in the drug should really think of ideas for studies. I think the most obvious example, although it would be challenging, would be emicizumab versus efanesoctocog alpha, and looking at various, not just, bleeding is going to be low for both, but looking at some other aspects, whether it's quality of life, whether it's activity, sports participation. There probably needs to be something like that done, because we don't have that head-to-head, two different mechanisms of action, kind of two different ways that the drugs, their pharmacokinetics work. EFA still does have peaks and troughs, although the trough is quite blunted, as you showed. Emi's flat. So I think that would be pretty interesting.
Yeah, I think that's what we would all like. Someone can do that. That would be great.
Yeah. It would be a challenging study to do, no doubt, but I think that would be interesting. Last question here is, can any of the new rebalancing agents be used in combination with other agents? I can take that one on first. I in a talk I gave a little over a year ago, I actually conjectured that we might start using some combination therapy. And, at the basis, why do we use combination therapy in other diseases? Well, the reason, those of us who I don't really do oncology anymore, but most of us on here have done oncology at some point or still do it. The reason why you do that is that you're using drugs with different mechanisms of action to try to have a better impact on the disease, so improve efficacy, and drugs who don't have overlapping toxicities, so you get less toxicity. I think in hemophilia A, we are going to start to see some of that. And in fact, I would argue that we are seeing it in some patients who have received gene therapy. So some patients on valoctocogene roxaparvovec, their factor levels are not undetectable. They're still detectable, and yet they've had bleeding, so they've started back on some sort of product. So they're kind of on some sort of combination therapy. But if the question is really about, can you use emicizumab and fitusiran together to improve the efficacy? That's something that we're actually looking at, in my lab to try to understand, what is the impacts of these two together in vitro. I absolutely, first of all, fitusiran is not available. Even when it becomes available, you absolutely should not combine the two. Let me make that crystal clear. Don't combine the two unless you're doing a clinical trial. But yeah, I think that we may get to a point where, if we're not getting the full satisfactory response, we may use them in some sort of combination, maybe less often, maybe at lower doses. So I think there's a lot to learn about that, and it'll be interesting to see how that transpires. But I think the main message is they have not been studied in combination. They're not going to be studied for the nearest future in combination. And when they're available, I would not advise doing that outside of a clinical trial. All right, well, thanks everybody. And I think that'll be it. And have a good evening or late afternoon if you're on the West Coast like me.
Thank you for listening to this episode of Practice Changing Updates, the evolving hemophilia treatment landscape.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.